Good morning, dear friends. I am Dr. Ashish Chakravarti. I am Head Pain Medicine Department of Neurosciences at Artemis Hospital, Gurgaon. Friends, atlantoaxial joint arthropathy can be a very important cause of cervicogenic headache. And if you are a pain specialist or if you are a headache specialist, you must know about this entity if you are having a patient coming to your clinic with cervicogenic headache. And it is very important to know the interventions for atlantoaxial joint arthropathy. Case presentation. So this is a history of a 68-year-old female who was a diabetic, and she had come to me with left suboccipital pain, which was there for around last 9 months. The patient was having pain, especially on side-to-side movement, as if when saying no, and the pain used to radiate from the suboccipital area to the vertex of the left side of the head. Under fluoroscope, the tenderness corresponded to C1, C2 joint. So we looked for the rheumatological factors like ESR and CRP, and also the RA factor and the anti-CCP, which all were negative. Subsequently, NCCT of the cervical spine was asked for, which revealed a normal right atlantoaxial joint and an arthritic left atlantoaxial joint. And you could see very well that there was evidence of erosive arthritis. So before we go on to the interventions per se, let us brush our anatomy. So if that was the atlantoaxial joint, you would see that at the middle of the atlantoaxial joint is the cervical, the C2 ganglion, and at the lateral edge of the atlantoaxial joint lies the vertebral artery. So if you have to land your needle, you have to be in the safe spot in between these two structures. And this would be the needle, the landing of your needle, which has to be exactly end on. So if we look at the fluoroscope image, if that is the vertebral artery, this is the place where your C2 ganglion is going to be, and this is the place where you would land your needle end on. So let's get ahead with the procedure. So we would want the patient to lie with the head flexed with a pillow under the chest. And having done that, the C-arm is positioned in AP view with a cranial tilt. Till the atlantoaxial joint comes in between the two incisors. Now, I don't follow the open mouth technique. Usually what I try to do is I just try to place the atlantoaxial joint in between the two incisors. So here, if you would see that I have had a cranial tilt of 17 degrees to place the atlantoaxial joint in between the two incisors. And to improve upon my accuracy, I follow the needle in needle technique, in which I use a 18 gauge hypodermic needle directed towards the atlantoaxial joint. And through that, I insert a 22 gauge Quincke spinal needle, and I direct that towards the atlantoaxial joint. And before I proceed further, I would like you to observe closely this particular line, and this line is what corresponds to the posterior capsule of the atlantoaxial joint, whereas the other line, which you can faintly notice, that is the posterior border of the odontoid process. So this is not the line which you would want to pierce, rather the faint line which you can see, this particular line is what is the border of the atlantoaxial joint. That is the capsule of the atlantoaxial joint. So using needle in needle technique, I pass the 22 gauge hypodermic needle through the joint and towards the joint. And the moment I see that it is tending to go in a correct trajectory in the lateral view. I move my C-arm in the AP view and I see whether my needle is corresponding to the area just described. That is in between the medial 2/3 and the lateral 1/3. And if my trajectory is satisfactory, I further pass the needle ventrally so that it enters the joint. When you are pushing the needle through the posterior capsule of the atlantoaxial joint, you must remember that there can be a meniscus inside the joint and there can be the cartilage which can be injured if you impale the joint, if you impale these structures with your hypodermic needle. So no undue force should be exerted while putting in the 22 gauge hypodermic needle, the 22 gauge spinal needle. And having confirmed the position of the spinal needle in lateral view and AP view, it is now time for you to inject the radio contrast. So the volume of the atlantoaxial joint is approximately around 1 ml. And what I do is I inject just 0.2 ml of radio contrast and not more than 0.5 ml of the actual drug which I intend to inject. And because I would not want to exert too much of pressure and I would want accuracy with my injectate, I usually prefer to use 1 ml syringe, which we pinch. So having done that, having injected the radio contrast, if my contrast pattern is confined to the atlantoaxial joint, I use my injectate triamcinolone, which I usually inject as 10 milligram. Or if I'm using the non-particulate steroid, I prefer to use dexamethasone 1 milligram. And this I give, this I administer in 0.5 ml or 0.5% PPVK. She reported post-procedure pain relief of approximately 80%. My further plan as a definitive treatment is to do an intra-articular RF lesioning of the atlantoaxial joint as well as intra-articular PRP injection for the same. There are certain things which I should have done and which have been missed by me as well. So you must know the apparent course of vertebral arteries. So in these two pictures, what you can see that there is a possibility that there could be aberrant vertebral arteries, and as you can see that aberrant vertebral arteries, they are passing in between the joints where actually you are putting the needle. So there is always a chance that while doing this procedure, you could have I could have punctured these vessels. So actually what I should have done is I should have also gone for the ultrasound Doppler of the neck. And if I am not an expert at it, I could have asked my radiology friends to do the same for me. So that's all regarding my presentation for the atlantoaxial joint. If you have further queries regarding this topic, I would be very happy to answer you, and you can always reach out to me at the detail provided.